I'm very pleased to welcome you all today to this official press conference highlighting the top HIV science from this year's International AIDS Conference, AIDS 2020 Virtual. I'm Dr. Monica Gandhi, Professor of Medicine at the University of California, San Francisco, and the Director of the UCSF Center for AIDS Research. I'd like to extend a special welcome and thank you for being part of our first fully virtual conference. In a moment, you'll hear brief remarks from our panelists, and we'll be glad to take your questions thereafter. If you have a question, you may submit them during speaker remarks by typing them into the Q&A feature. Please either type your question in full or just type the word question and we'll unmute you to pose the question directly to the panelists. In both cases, please be sure to list your outlet. We will take as many questions after we hear from our speakers. Each speaker will be sharing study results today from their studies, and the embargo will be lifted officially for all of these studies at this moment. So our first speaker is Dr. Raphael J. Landowitz, and he is the HPTN 083 Protocol Chair, a professor of medicine in the Division of Infectious Disease at the David Geffen School of Medicine at the University of California, Los Angeles, and co-director of the UCLA Center for Clinical AIDS Research and Education. He will now discuss data from the HPTN 083 study on long-acting injectable cabotegravir for HIV pre-exposure prophylaxis or PrEP. Rafi, please go ahead.
Thank you, Monica, and thanks everyone for joining this morning. It's a great honor to be able to discuss these HPTN 083 final trial results. The context of this study is that despite remarkable efficacy of daily oral TDF-FTC to prevent HIV infections in diverse transmission contexts and populations, its public health impact has not delivered uniform benefits to all populations. Those disproportionately affected by HIV are the same populations that have not found equal access, uptake, adherence, and persistence to oral tablet-based pre-exposure prophylaxis. The goal of HPTN 083 was to establish the preventive efficacy of long-acting injectable cabotegravir in cisgender men and transgender women who have sex with men globally. Cabotegravir, just to briefly review, is a novel integrase strand transfer inhibitor chemically similar to Dolutegravir that is formulated both as a short-acting oral tablet for daily administration and as a long-acting injectable suspension for intramuscular administration. Currently, injectable cabotegravir has been studied most extensively as a gluteal or buttock injection. Cabotegravir is being simultaneously developed for treatment of people living with HIV in combination with long-acting injectable rilpivirine, as well as for HIV prevention as a PrEP agent. 083 is an ongoing phase 2b/3 randomized double-blind clinical trial that we conducted at 43 sites in North and South America, Asia, and Africa, comparing PrEP regimens containing long-acting injectable cabotegravir and daily oral TDF-FTC. The study enrolled cisgender men and transgender women who have sex with men at increased risk of HIV infection, age 18 and older. And the planned enrollment was 5,000 participants. The primary objectives were HIV prevention, efficacy, and safety. The study randomized participants in a 1-to-1 ratio to either active cabotegravir, initially oral for approximately 1 month to establish safety and tolerability, then injectable, or active TDF-FTC daily. This blinded randomized component was to last for 3 years, and all participants received 1 active and 1 placebo drug at all times during this blinded portion of the study. Participants who chose or needed for safety reasons to stop their injections before 3 years were given 48 weeks of open label TDF-FTC after their final injection to cover the pharmacokinetic tail of the long-acting injectable cabotegravir. The study was reviewed regularly after its initiation in December 2016 by the NIH DSMB and had pre-specified interim analyses when 1/4, half, and 3/4 of the protocol specified HIV infections had occurred. The first such analysis took place this past May. And at that DSMB meeting, they recommended that the blinded comparison be terminated, the results be made public, and all participants be offered cabotegravir if they so chose, as soon as sufficient drug supply could be made available. The time of cessation of the blinded portion of the study, we'd enrolled 4,570 participants. Participants who were found to have acquired HIV prior to administration of any study products, and participants who did not come in for any follow-up visits were excluded from the primary efficacy cohort that I'll be reporting on. The study population was very diverse by intention, 2/3 under the age of 30, almost 13% transgender women, and 50% of the US enrollment were Black or African American self-identifying. We found 52 incident HIV infections. The overall incidence rate in the population was 0.81%. In the cabotegravir arm, we found 13 incident HIV infections with an incidence rate of 0.41%. In the TDF-FTC arm, we found 39 incident HIV infections for an incidence rate of 1.22%. The hazard ratio between the two arms was 0.34. That's 66% fewer HIV infections in the participants receiving cabotegravir compared to those receiving TDF-FTC. The 95% confidence interval on that hazard ratio was 0.18 to 0.62, which excludes the pre-specified non-inferiority margin, which was 1.23, the superiority boundary, unity 1.0, and also the protocol's pre-specified alternative hypothesis of 0.75, definitively establishing superiority of cabotegravir compared to TDF-FTC. Unfortunately, due to delays in complexity in sample shipping and laboratory activities in the setting of the global SARS-CoV-2 pandemic, I do not have drug concentrations nor resistance testing results from any of the incident or prevalent infections found in HPTN 083 to present to you today. We look forward to sharing that information as soon as it can be made available. Of the 13 HIV infections diagnosed in participants in the cabotegravir arm, 5 were diagnosed after a prolonged hiatus from cabotegravir treatment, 3 were diagnosed during the oral lead-in period, and 5 acquired HIV despite, as far as we're able to ascertain, good oral lead-in adherence and on-time cabotegravir injections. The cabotegravir concentrations that are associated with these specific infections are particularly critical to understand. Some diagnoses were delayed by cabotegravir PrEP use, which delayed site-based testing identification of infections. This is true of TDF-FTC PrEP as well. We do not yet have tenofovir drug concentration specifically in the 39 participants who acquired HIV in the TDF-FTC arm, thus we're unable to confirm their adherence to TDF-FTC at the time of their diagnosis or prior. We're pursuing these samples and assays presently. We have an overall estimate of TDF-FTC adherence in the 083 population from a random adherence sample, and 76% of dried blood spot samples and 75% of plasma samples had drug concentrations suggestive of adherence that should provide high levels of rectal protection. Again, that does not necessarily include any of the persons who acquired HIV on the TDF-FTC arm. In terms of safety, injection site reactions were extremely common, with 81% of cabotegravir recipients and 31% of placebo recipients reporting any injection site reactions, but most were mild to moderate and decreased over time. Only 2.2% of those who received at least one active cabotegravir injection stopped injections due to side effects. Other adverse events that were imbalanced between the arms included decreases in kidney function in the TDF-FTC group, nasopharyngitis, blood glucose, and fever being more common in the cabotegravir group. The fever was associated with injections. More severe adverse events were balanced between the groups. STIs were frequent, syphilis incidence was 16.5%, and rectal gonorrhea and chlamydia combined were over 27%. Overall, interestingly, we found there was more weight gain in the cabotegravir treated participants than the TDF treated participants, but this was driven by in the approximately the first year of treatment, there was actually a 0.5 kilogram weight loss in the TDF-FTC arm, and then afterwards, nearly identical weight increases in both arms. We look forward to being able to share the drug concentration and resistance data fully that will let us understand the clinical implications of all of these provocative findings and exciting results. Our conclusions are that both products reduced HIV incidence compared to the expected background incidence rate dramatically. Cabotegravir was superior to TDF-FTC in this population, with 66% fewer infections of HIV occurring in participants randomized to CAB compared to TDF-FTC. Both were generally well tolerated, despite high rates of injection site reactions in the CAB arm. Having the drug concentrations and resistance data in those who acquired HIV will be really critical to a full understanding of the relative advantages of each PrEP regimen. It's tremendously exciting to have data that will hopefully support regulatory approvals of an additional PrEP agent to increase choices for HIV prevention. And we eagerly await the results of our sister study, HPTN 084, being conducted in cisgender women in sub-Saharan Africa and companion adolescent bridging studies. I'll stop there. Thank you.
Thank you so much, Rafi. That was quite an update from the abstract. And exciting. So our next speaker will be Ricardo Diaz of the Federal University of Sao Paulo. He will share a report on what may be the first adult with HIV to achieve at least 57 weeks of long-term HIV remission without a bone marrow transplant. So Ricardo, please go ahead.
Thanks for the opportunity. This is a case of a 35-year-old MSM Brazilian Caucasian male. He's been on regular antiretrovirals for 2 years. Then he was recruited in our study and randomized to receive on the top of the antiretroviral treatment, Dolutegravir, Maraviroc, and nicotinamide for 48 weeks. We knew that Maraviroc was a latency reversal agent, and also we described that nicotinamide has that property of being a latency reversal agent besides boosting the immune system. So he's been for 48 weeks in this scheme, and he had during the study a decline in cell activation, in the inflammation, and a very deep decline in the antibody titers. He had 2 viral blips during the study, and we were monitoring viral loads every 4 weeks. And he had the DNA present in PBMCs and retinal biopsy by the end of the study, as well as during the study. Then he returned to the regular ART scheme right before the 48 weeks, and stayed being treated like that for almost 3 years. Then he was again invited to proceed with the analytical treatment interruption. And interestingly, right before the analytical treatment interruption, the DNA, the HIV DNA in PBMCs were completely negative. Then he's now been for 64.7 weeks, the last time that we checked for the viral load, with the viral load below detection limit, the undetectable viral loads. We also performed culture of the PBMCs, the cells with different latency reversal agents to stimulate the virus, and we're not able to get any virus. And some patients in treatment were used as control, and we always were able to get virus with our cultures. He was still with the antibody titers declining during the period, almost 3 years period, that he was not being doing any further intervention. And during the ATI, the analytical treatment interruption, he's still with a decline of the antibodies. And this is not in the abstract of the presentation, but we have an early spot at week 12 of the ATI that's completely negative with the stimulus of GAG, common GAG antigens, a cocktail of common GAG epitopes. And now I stop there. Thank you. I think you're muted, Monica. We can hear you.
Sorry about that. Okay. I'm excited that that went on longer than your extension of viral load suppression has been longer than first reported in the abstract. So our next speaker is Dr. Rebecca Zash of Harvard Medical School in the Botswana-Harvard Institute Partnership. And she will update us on an observational study in Botswana, which was, among other things, investigating a potential link between Dolutegravir and HIV medication used for treatment and neural tube defects in children born of mothers on Dolutegravir. And this is an important topic because Dolutegravir is widely used around the world and is now first-line therapy in the WHO treatment guidelines. So Rebecca, please go ahead.
Thank you, Monica. Can you hear me? Yeah.
Yes.
So my name's Dr. Rebecca Zash, and I'm here to discuss our updated data from the SAPAMO study. SAPAMO is a large birth outcome study funded by NICHD, and it started in 2014. It collects data at the time of delivery throughout Botswana to look for differences in adverse birth outcomes, including birth defects, by maternal HIV status and the ART regimen taken during pregnancy. In May 2018, SAPAMO first reported a preliminary safety signal associating neural tube defects with exposure to dolutegravir at conception. And at that time, we had found 4 neural tube defects among 426 women taking DTG at conception, a prevalence of almost 1 neural tube defect per 100 births, which was way higher than the expected prevalence of 1 neural tube defect per 1,000 births, and also significantly higher than all the other comparator groups, which included women on other non-dolutegravir ART at conception, women specifically on efavirenz at conception, women who started their dolutegravir during pregnancy, and women without HIV. And these preliminary findings led to warnings from FDA and EMA, and stalled the planned global rollout of DTG, and really adversely impacted treatment options for women living with HIV around the world. At IAS in Mexico City last year, SAPAMO reported our updated analysis using data from the beginning of the study through March of 2019, with a total of 5 neural tube defects in 1,683 exposures to DTG at conception, a prevalence of 0.3%, or about 3 neural tube defects for 1,000 births. And although this was much lower than the initial report, it still remained higher than the comparative groups. And the SAPAMO study continued. So now we're able to report on 13 additional months of data, with a total now of more than 158,000 births up through April of 2020. And since March 2019, we had 2 more neural tube defects among 1,908 additional exposures to dolutegravir at conception, for a total prevalence of 7 neural tube defects in 3,591 DTG conception exposures, a prevalence of 0.19%. And if you look at how the prevalence of DTG changed over time, after a period of decline since the original safety signal in May 2018, the prevalence of neural tube defects among infants born to women on dolutegravir at conception appears to be stabilizing right around 2 NTDs per 1,000 births. And it's really only about 0.1% higher than women on efavirenz at conception and women without HIV. This small absolute increased risk of NTDs is really far outweighed by the potential benefits of DTG. And our continued reassuring data should allow for broader use of DTG in women. And I think if there's really one thing that SAPAMO and the DTG story has taught us, it's that women aren't a niche population in HIV. They make up half of the people living with HIV, and maintaining gender equity in HIV treatment outcomes really requires pregnancy safety data. This is an important lesson, not just for future HIV treatments, like 2-drug therapy and long-acting injectables and BNABs, but also for coronavirus, which also impacts women of reproductive age. And if we don't include pregnant women in therapeutic and vaccine trials for COVID-19, we really aren't protecting women, we're failing them. Thank you.
Thank you so much, Rebecca. It's super reassuring to hear that third and presentation from the SAMA cohort as it goes down and down this incident. So our next speaker is Simiso Sokelo of the University of Witwatersrand in Johannesburg, South Africa. And she will share results from the ADVANCE study, which is a phase 3 randomized trial in South Africa comparing dolutegravir combined with either TDF FTC or TAF XTC to efavirenz TDF XTC for first-line HIV treatment. And Simiso, please go ahead.
Hi, thank you for the opportunity. I'm Simiso Sokela, and I'll be presenting the advanced 96-week trial data. So the data I'm about to present reaffirms the results that we presented at IAS in 2019 and published in the New England Journal of Medicine in August 2019 of our 48-week data. So ADVANCE is an investigator-led clinical trial that was set in South Africa, comparing Dolutegravir and 2 formulations of TDF with the standard of care. South Africa has a background in NRTI resistance estimated to be about 5 to 15%. And we started ADVANCE with that information, and patients were randomized into 3 arms, and they were being followed up to week 96. So I'm presenting the week 96 data. So first of all, this is a first of 2 ADVANCE presentations. The other one with pregnancy outcomes will be presented on the 9th of July. And the ADVANCE paper will imminently be published, and it will give more details about the study and the 96-week results. And we also believe that this study is representative of the patient populations that end up using these antiretrovirals. The primary efficacy endpoint of the study used the HIV RNA levels at the week 96 time window. You must note that patients who had an RNA that was more than 50 copies per mil were counseled on adherence and retested within the 96 time window. In terms of proportion of participants with undetectable viral loads, we had no significance across all the arms. And we actually had no significant differences between the groups across most of the measures. We had no participants developing integrase inhibitor resistance across all the arms. The biggest finding that is of concern to us was the mean change in weight for both men and women, more concerning for women. At 96 weeks, women who were on the TERF arm had gained 8.2 kilograms compared to 4.6 kilograms on the ones who were on the DTG TDF arm, and 3.2 kilograms on the ones that were on the efavirenz arm. We also noticed that the mass increases were largely fat over lean gain, and they were distributed between the trunk and the limbs across all 3 arms in the study. The gain in fat mass was significantly more in women than men. The study concluded and proved that there were no statistically significant suppression rate changes across all the arms, and this was seen in both intent to treat and observed data analysis. There was, however, the slightly higher risk of treatment emergent NRTI and NRTI resistance in the efavirenz arm, which was the standard of care arm in the country at the time. Patients on the TEF arm had significantly higher mean rises in body weight, which were greatest in women as evidenced in the 48 weeks data, and it seems to be continuing post the week 96 time window. These weight rises also had a higher risk of metabolic syndrome in the TEF arm. And these results, we believe, they support the current WHO treatment guidelines, reserving the TEF and DTG only for patients with osteoporosis or impaired renal function. Our pregnancy data, which will be presented on the 9th of July, shows that among women with normal body weight at baseline in our study, 40% became clinically obese at 96 weeks. And as a result, the analysis or the predictions presume that there will be higher risks of adverse maternal and infant birth outcomes if the patients are treated long-term with TEF and TDF combined with DTG. These risks could increase further for women treated long-term because the risk of clinical obesity continues to rise after the week 96 window. So we are recommending that further safety evaluations be done regarding the combination of TEF, FTC, and DTG, and other integrase inhibitors in treatment guidelines. I will stop there.
Thank you so much, Smiso. This is adding to other weight gain data from the meeting. on TAF, and great to see the long-term efficacy. So our final speaker will be Dr. Catherine Kloss of the University of California, San Francisco, and she will discuss interim results from the SEARCH PrEP study, one of the largest studies ever conducted in East Africa, which looks at the impact of PrEP on HIV incidence in 16 rural communities in Kenya and Uganda. Catherine, please go ahead.
Thank you. Good morning and good evening, everyone. Oral PrEP is highly effective for HIV prevention, but we need better, lower barrier approaches for delivery in sub-Saharan Africa. HIV testing is the entry point for PrEP, and community-based HIV testing is an alternative to testing at health facilities that is more accessible for groups like young adults and men. Community testing can also provide an opportunity to offer and engage people in taking PrEP. So we offered a low barrier model for PrEP delivery during community-wide HIV testing in 16 communities in the SEARCH study in rural Kenya and Uganda. And to do this, we offered universal access to PrEP. We had an inclusive approach to PrEP eligibility for individuals in serodifferent partnerships, those identified by an HIV risk prediction tool, and those who self-identified as being at risk of HIV. We provided same-day PrEP start on-site during community-wide testing at health fairs. And then we provided a flexible care delivery model with follow-up visits at clinics or community-based sites where people could receive repeat HIV testing and PrEP refills. So what did we find? There were 74,541 individuals who tested HIV negative in the study. Of these, over 15,000 were assessed to be at elevated risk of HIV, and 5,447, or 35%, started PrEP. In terms of HIV incidence, there were 25 seroconversions over 7,150 person years of follow-up for an HIV incidence rate of 0.35 per 100 person years. The HIV incidence in women was 0.46 and in men was 0.23. We next asked, what would we have expected HIV incidence to be in this population without PrEP? And to do this, we used propensity score matched recent controls from the year before PrEP was available in 8 of the 16 study communities. And doing this, we would have expected an HIV incidence of 0.92, but what we observed was an HIV incidence of 0.32, representing a 74% reduction in incidence compared to expected. We also found a 76% reduction in incidence among women and a 40% reduction in incidence among men. So what are the implications of this work? Well, we think that these results show that in generalized epidemic settings, offering universal access to PrEP can reduce HIV incidence. And moving forward, having comprehensive HIV testing with linkage to treatment and prevention, including PrEP with flexible service delivery, is a promising approach to accelerate reductions in new infections. Thank you.
Thank you so much to all the presenters. And now we're going to take questions. There are a couple of questions that are going to be, I'll just ask for you to be unmuted. But I will start with a couple for Dr. Diaz. Dr. Diaz, how long has it been since his ATI? I believe you updated it to 64.7 weeks now. Is that correct?
Yes, 60.7, the last viral load. That was on June 22nd, that the viral load was performed. Just looking here, the ATI start on March the 28th, 2019.
Okay, and did you, this is from Heather Berner from Medscape, did you test for antiretroviral levels?
Not yet. It's planned. This study was partially supported by Viv Healthcare as an investigator-sponsored initiative. And I asked them right now to search for drug levels. But it's very interesting because in Brazil, all the antiretrovirals are through the public system. So it's not for sale in pharmacies. We don't have black market because we don't need this. You just go to the public system and you get this. And of course, every time that you go there, you register that you get the medication. And I was able to check that. After someone raised the point of being treated, I went there. There is no registry that this patient get any drugs from the public system. But nonetheless, we need to check, to monitor for drug levels.
And then finally, just one more question for you, Dr. Diaz, that, I mean, does this for you give you a take home that patients should be taking nicotinamide? And then one quick question, is he 34 or 35, the patient?
It was 34 by the time we submit the abstract. It's now 35.
Okay, I actually am gonna, based on the question, I'm gonna very quickly offer a brief perspective on these presentations, just very quickly. This will take me 1 minute. I don't actually think that it's time to start nicotinamide on every patient. I think, Dr. Diaz, you would agree that we do need more data from more individuals than one, and we do need to know how long he was infected, and we do need to watch him for longer. And in terms of the PrEP study in Kenya and Uganda, the Search PrEP study, I think it's amazing that how effective it was for women, because I think that there's been questions about women versus men, and I think in the setting of community offering, I think it's a very take-home point from this study that women can adhere to PrEP, and there was massive reductions in HIV incidents. And then in terms of Dr. Zash's study, my perspective would be that I think this is the time, like Rebecca said, to lay this to rest for now, given the incredible benefits of Dolutegravir, and to have one therapy for both men and women worldwide, but to do studies in the future for any new drug in women, in adequate numbers of women. And then Rafi got a lot of questions, and I will ask them, but I think cabotegravir is exciting to be able to give preventatively every weeks, and we really do need to understand if you fail with resistance, which that data will be forthcoming, but this is incredibly important data. And then the advanced study, dolutegravir is the right choice over efavirenz because we've now studied it in the right populations, but and out to 96 weeks, but I do think the weight gain with TAF needs to be examined further. So this is a question for Rafi. There's a couple of here. So one, and then I will unmute the people who've asked, want to ask their questions. So from Benjamin Ryan, original 083 was supposed to go to have out longer. How you were gonna actually have them go out of LA Cab and then go have 1 year of Truvada, I didn't know that. But how is the part of this trial gonna change now that the DSMB has found LA Cab to be effective? Are you going to continue to follow these patients out for the duration of follow-up, and how will they be followed?
Yeah, thanks for that question. So the 1 year of TDF FTC that's provided when someone stops injections is designed to provide ongoing protection for individuals of persistent sexual risk who decide to go off the injection. So that will not change as the study goes forward, that tail coverage, if you will. At this point, everyone is in the process of being unblinded as soon as individual sites IRBs have okayed that process, and people for the moment are continuing on their original randomized treatment regimen until we can get appropriate supplies of cabotegravir to each site to offer either the injectable or continuation on the oral as per people's choice to the participants who are on study. So people will be able to stay on injectable if they've transitioned off injectable and want to go back unless there was a safety concern for their original transition off it. They will be able to resume it, and people will be able to switch from oral to injectable if they so choose. People will also be able to stay on the tablet version until the planned original end of study follow-up if they choose to do that, and then they'll be referred to local prevention services after that. The length of the planned injectable open label extension is still under discussion. Right now, we're in the process of amending the protocol and having lots of discussions with all the stakeholders to figure out what the most appropriate timing is, particularly relative to anticipated regulatory submissions.
Okay, thank you. And a question for Rebecca, would you now at this point recommend dolutegravir would you recommend dolutegravir at all points in pregnancy, really? And then the other question to you is, what do you think about folate supplementation in countries that don't traditionally offer this?
Yeah, I mean, the second question is easier. I think folate supplementation is a no-brainer. You know, if we care about preventing neural tube defects, we know that there's, you know, that supplementing with folate, especially putting it into food so that everybody gets it pre-conception, will reduce neural tube defects by at least 50%. So that needs to happen everywhere. We've been a huge advocate for that, and it's been really slow to develop in a lot of countries. And in terms of sort of recommendations about dolutegravir, you know, I think that it's pretty clear from WHO guidelines for over a year, DHHS guidelines in the US since December, that dolutegravir should be part of a first-line recommended regimen for women. And it's still an alternate in terms of DTG for women who are trying to conceive. But again, I think that when you sit down with a woman and you think about the risks and benefits, this sort of very small potential risk has to be balanced by all sorts of benefits of DTG for tolerability. And again, there's bigger issues now with sort of weight gain and other things that may have much larger impacts on the women that also need to be considered.
Great. And then I'm going to ask a question of Dr. Koss, and then I'm going to go to the open ones. And this is from Medscape as well. What do you think is the significance, Kate, of your sex differences that you found in the efficacy of PrEP, especially based on what we know, what we've seen in clinical trials?
Yes, thanks for the question. So in terms of the incidence rate ratio, what we saw for the overall study for men and women was an incidence rate ratio of 0.26. That was statistically significant with a 95% confidence interval from 0.09 to 0.75. For women, we also saw a statistically significant reduction in incidence. So the incidence rate ratio was 0.24, confidence interval 0.07 to 0.79. And for men, we saw a 40% reduction that was not statistically significant, 0.60 confidence interval from 0.12 to 3.05. So in terms of the reductions in incidence that we saw among women, we think that this really adds to the accumulating evidence from open label studies that PrEP is effective, that it works for women and that women want to take it. So this adds to the data that says that PrEP works. We found that among men, there were only 8 seroconversions. And so we saw a reduction in incidence. It was not statistically significant, potentially due to limited power to detect a difference there. And we may have seen actually less of a difference in incidence in men because of slightly lower PrEP coverage in that group when we look at how people followed up for refills and reported adherence over time. We think finally that having a flexible model for PrEP delivery in this case may have also helped allow women to match periods of PrEP use with periods of risk. So we found that many individuals, far more than half in the study, stopped PrEP use at some point during the study, and half of them restarted PrEP. So that flexibility may have been important as well in the incidence results that we saw. Thanks.
And Roger Puberty, please unmute or we'll get you unmuted. And please first ask your question for Dr. Sakalo first for the advanced study.
Okay. Hi, thank you. My question is, obviously we had the 48-week data before, and it feels like the 96-week data are confirming what we found out previously. But maybe I'm missing something. Is there some nuance? Are there some key findings that we're more confident of now with the 96-week data?
So the question for you is what is the new thing that we've learned from the 96 versus 48, or is it pretty much the same?
So it's pretty much the same, but it's laying to rest the question of whether the weight increases were increasing with time. So we are proving that the changes in weight are actually worsening with time. And we have a few patients who've developed metabolic syndromes. So we are worried about the outcomes or the implications of the weight gain even with pregnancies, we're predicting that there might actually be more instances of pregnancy-related adverse events because of the weight gain. So there's nothing new except to reaffirm what we had already found and to show that actually we are getting more problems because of the weight gain.
And I don't know if you can answer this, maybe Leila can or Bijan, but is the pregnancy data you presented that's going to be presented on the 9th, is that embargoed? Or can we still, maybe Leila or someone can type to me if that can be reported upon?
Well, I'm not sure about being embargoed, but yeah, it was just that part was part of my presentation, was part of the advanced presentation that I prepared.
I think someone will tell me. And then the next, Roger, could you please ask Dr. Rafi your question as well?
Cool, thank you. When the headline findings came out a few weeks ago, there was some sort of incredulity in some people in the community. And I think it seemed to be related to having a comparator on the standard of care that we already know is extremely effective. So my question is, what do the findings tell us about the effectiveness of TDF, FTC, oral PrEP?
Yeah, thank you. I think it's a really important point, and thanks for the opportunity to try and provide some perspective on that concept. I think one of the one thing I would like to not come out of these data is any impugning of the really impressive efficacy of TDF, FTC. We know that it works extraordinarily well if taken as prescribed. Of course, we know that there's more forgiveness to missed doses for rectal protection than there is for vaginal protection. And I think it's in that context of likely non-adherence, missed doses, challenges to tolerability, access, persistence to daily oral tablets, or even oral tablets in general, that provide an opportunity for something to provide more consistent coverage of sexual acts that is likely the driver of these findings. Again, having the drug concentrations that indeed will confirm or refute that these 39 HIV infections that were acquired in the TDF FTC arm in HPTN 083 indeed were all attributable to those participants not consistently taking their TDF FTC product, and then a nuanced understanding of what was permissive to the HIV acquisitions in the Dolutegravir arm will be really helpful in disambiguating and clarifying these results.
So thank you so much. So yes, I think the July 9th abstract presentation of advance that you mentioned, Sohaila, because it's a population within your study, should be off embargo. This is a question for Dr. Diaz that a couple of questions, two questions actually. One is, what's the theory behind administering nicotinamide? You said a latency reversal agent. This is an old drug. And the second question is, just given the implications of this, do you plan to send samples to verify your findings to other laboratories?
What's very nice is we have samples. We have every 4 weeks, we have blood, PBMC, saliva, urine. And this is all available for research. So this is something that we really like. The thing about nicotinamide is that we saw, looking at the mechanism, that nicotinamide is able to revert latency by 2 mechanisms. It's a HDAC inhibitor. So when you block SIRT1, you can reverse cell latency as any HDAC inhibitor. And also, it can stimulate methyltransferase enzyme. So the 2 mechanisms of latency are either by nicotinamide or NAD are going to be solved. And also, the acetylate stat, which also is going to increase the transcription. So we have those mechanisms, nicotinamide. Nicotinamide was for HIV anti-apoptotic agent, and we know that this makes the CD4 healthier. And also in animal models, we see that nicotinamide was able to increase the CD4 and CD8 activate for murine melanoma. So we are believing that's our hypothesis that nicotinamide would boost the immune system of those patients after and together with reversing latency.
Dr. Diaz, just to be very specific with those samples that you have, it sounds like you have a lot of great samples. Are you already working with another lab or confirmatory group to send them out, or that is something that you would consider?
Not yet, but I, of course, would consider because our lab has lots of resources, but many things are arising. So we are doing metabolomic. We have many things to do yet, but I sure consider to make these samples available.
Okay, and this is a question for Rafi. Do you, and this is from a journalist from the Sunday Times in South Africa, when do you expect CAB long-acting to be on the market, and will it be available in your estimation for countries where it was tested, such as South Africa?
Yeah, great question, thank you. And I need to refer all questions about regulatory approval timelines, pricing, and availability to our colleagues at ViiV, who are doing the regulatory submissions. And I'll be happy at the end, or through you, Monica, to provide the intake person, the contact at ViiV, who will be answering all those questions.
And one more question, Rafi, is what's your take home for providers, and how would you plan to counsel patients on whether to use CAB or TDF? You think it's or Descovy, so mainly maybe you're going to say it's a choice.
I am going to say that. For me, the most exciting thing about 083 is that we're likely going to be expanding the toolbox of options, at least at this point, for cisgender men and transgender women who have sex with men, hopefully soon to also include cisgender women in sub-Saharan Africa. It'd be great to have data in people who inject drugs and in transgender men as well. But we would, we know that TDF FTC PrEP works extremely well in all those populations. Let me rephrase, we don't know so well in transgender men yet. We need more data there. But in those other populations, we know works extremely well if taken as prescribed, and to have another option for people who are challenged by pill taking, find it stigmatizing to take pills, forget to take pills, have other priorities, or have limited access to contexts in which they can take pills is tremendously exciting. And again, receptive partner or HIV uninfected individual controlled prevention, so important globally that I just think to have an additional option that is highly effective and doesn't require a daily activity for efficacy is the really exciting progress that this study represents.
I mean, I also think to put themes together from Kate and Rebecca's presentation, it's imperative to study these preventative options in women. So the HPTN 084 cisgender women study is imperative. I think we've seen some examples this year where we didn't get that. You will be able to get slides from these presentations. Just follow up with the media team. That was a question that was asked. And I think a final question, unless, I mean, this is a hard one to answer, Kate, that how can we, this is from the press in El Salvador, that how can we get Central American governments to expand PrEP more? I think this is a harder question to answer, but I agree that it needs to be talked about more and it needs to be worldwide.
Yes, it's such an important question. We've known for many years that PrEP is very effective. This is adding to that evidence base that there's high effectiveness of PrEP. I think potentially approaches to normalize PrEP use to make it broadly available and to think about HIV testing as the entry point for PrEP may help to sort of encourage some of those conversations. We also know that broad access to testing is important for reducing HIV incidence. Across the universal test and treat trials, even without PrEP, offering universal access to testing and linkage to treatment reduced HIV incidence by about 30%. So this is adding on top of those gains. And if we're really going to drive down incidence to elimination levels, we need, broad access, universal access to testing. We need to be linking people to treatment and prevention and providing flexible models for PrEP delivery as a way to continue to drive down infections.
And I think one final one for Rebecca from MD Edge, Mitchell-Zoller. You had mentioned some of the attractions of using dolutegravir for treatment. I imagine you meant tolerability and high barrier to resistance. Any other attractions? I think having one medication and not dividing it into groups is also helpful.
Yeah, I mean, I think those are there's nothing new that I know that hasn't already. It's tolerability, fewer side effects, and generally speaking, fewer drug-drug interactions as well.
Yeah, I agree. I think that's it, unless anyone wants to say one more thing. I think that these presentations are going to be today and over the next couple of days, and we will definitely get you the slides. Just follow up with the media team and they'll get you the slides. And thank you so much for the panelists for these incredibly important presentations. And we really look forward to your full release and hearing your talks later this week. Thank you again.
Thank you.
Thank you.
Thank you.